We talk about spores in other parts of the chapter. Remember that Bacillus and Clostridium species can form spores when they are nutrient depleted. Spores can only be killed by autoclaving above a specific temperature, 121 degrees for 15 minutes, which is done for all surgical equipment. Instant hand sanitizers are not effective against spores, and therefore hand washing is necessary to remove these spores that may have been acquired from patients in the hospital with infections such as Bacillus or Clostridium. This is the only way to prevent spreading of those infections to other patients. Clostridium is a genus of spore-forming anaerobes with 4 major species. Clostridium tetani and botulinum are the 2 major neurotoxic Clostridia. Clostridium perfringens is the major histotoxic species causing gas gangrene. C. difficile is also histotoxic in the colon, causing pseudomembranous colitis. Let's talk about each of these 4 species next. Clostridium tetani produces spastic paralysis, as you can see in this baby, by blocking the release of inhibitory neurotransmitters, glycine and GABA, and causing prolonged muscle contraction known as tetany. Some of the physical exam findings in tetanus include a condition known as rhizus sardonicus, characterized by abnormal spasm of facial muscles resulting in strange grinning appearance of the face, which is seen in this image. Tetanus is associated with deep wounds or skin punctures with rusty nails that harbor the bacterium, acting commonly as the culprit. The reason that the nails are usually rusty in these cases is because the spores tend to adhere better to a rough or rusty surface rather than a smooth surface. Today, however, tetanus is rarely a problem due to vaccination, again, with the DTaP vaccine, as long as your patients have been receiving their boosters. Clostridium botulinum can also cause paralysis, but this is a flaccid paralysis due to inhibition of acetylcholine release from the presynaptic terminal. So here's our presynaptic terminal. Maybe that's our muscle fiber there. You have little vesicles containing acetylcholine. Botulinum toxin is going to block that release, and you don't get muscle contraction. The paralytic effect of Clostridium botulinum has found widespread medical use in the form of botulinum toxin, or Botox, for purposes ranging from diminishing the appearance of wrinkles to alleviating chronic migraine pain or excessive sweating. The spores of Clostridium botulinum have been found in bottles of honey. Babies are susceptible to the spores because they have less competing normal flora in the colon. As a result, babies should not be fed honey in order to prevent a neonatal form of botulism known as floppy baby syndrome. When botulism is suspected, you can find the bacterial toxins in the stool. Note that in adults, it is the toxin that causes disease, while in infants, the spores will germinate to form the bacteria that then produce the offending toxin. Clostridium perfringens infections should be suspected in wounds that are gangrenous and foul-smelling. These infections are common in wounded soldiers. So, if I tell you that the disorder is called gas gangrene, and you find air in the subcutaneous tissue on imaging, then what physical exam finding would you expect? The answer is crepitus, which literally feels like you are pressing down on crispy air-filled cereal. It is a pretty unmistakable finding. Finally, Clostridium difficile infections causing pseudomembranous colitis. These are extremely important for you to know. An image of pseudomembranous colitis is shown here. Clostridium difficile is a bacterium that naturally resides in the gut and normally does not cause harm because it is restricted from overgrowth by normal gut flora. 2 toxins released by C. difficile commonly cause the disease: toxin A and toxin B. Toxin A is an enterotoxin that leads to accumulation of neutrophils, mucosal inflammation, and loss of water into the gut. This causes diarrhea. Toxin B is a cytotoxin that affects cytoskeletons, leading to cell death and mucosal necrosis. On your boards, you might be asked about which toxin causes the diarrheal symptoms of C. difficile. So which one would you choose? The answer is toxin A. Okay, so your 65-year-old male patient is admitted for pneumonia and started on broad-spectrum IV antibiotics. 4 days later, he develops fever, chills, and foul-smelling diarrhea. What is your most likely diagnosis? C. difficile colitis. And how might you confirm this diagnosis? Well, the best way to do it is to send a stool toxin assay for C. difficile, which will tell you if the toxin is present in the patient's stool or not. Once you have your result, you can start treating your patient. But wait, which antibiotics commonly cause C. difficile? The answer is ampicillin and clindamycin. Just remember that. While these are the antibiotics most commonly associated with infection, really any antibiotic can lead to pseudomembranous colitis. And how are you going to treat your patient's infection? There are actually two things that are commonly used. You might see oral vancomycin or IV metronidazole. Don't forget to put your patient under isolation with contact precautions while you are ruling out C. difficile. C. difficile infections are particularly problematic in hospitals where spores can be transmitted by us, the healthcare professionals. The healthcare professionals will actually deliver this from one patient's room to another. You will undoubtedly see this infection in the hospital. Therefore, it is important to follow contact precautions and wash your hands with soap and water after visiting C. diff positive patients. This prevents transmission of their spores. Take-home point. If your patient has been on antibiotics and develops diarrhea with signs of infection like fever and pain and an elevated white blood cell count, you should definitely consider C. diff. Let's do a quick review. Clostridium tetani impairs the release of which neurotransmitter? GABA and glycine. And Clostridium botulinum impairs what? That's right, acetylcholine release. Bacillus anthracis is a gram-positive rod that produces spores and anthrax toxin. You may recall the anthrax attacks of 2001, during which envelopes containing anthrax spores were sent to several media offices. In recent years, anthrax has received much media attention due to its potential use as a bioweapon. Bacillus anthracis can only be transmitted via spores and presents differently depending on the route of contact. Ingested anthrax spores cause gastrointestinal anthrax, which is highly lethal, but also very rare. Skin contact with anthrax spores causes cutaneous anthrax, which presents as a painless ulceration at the site of contact that goes on to become a necrotic black eschar. Here's a patient with the black eschar of cutaneous anthrax. Systemic disease, such as bacteremia, leading to death, can also result. Do you remember the two toxins of Bacillus anthracis that we discussed in the basic micro lecture? They are responsible for the formation of the eschar, and they are edema factor and lethal factor. Inhaled anthrax spores cause pulmonary anthrax, which can cause non-specific flu-like symptoms such as fever, headache, cough, malaise, and chest pain. So fever and cough. Let's hang on to those for a second. Untreated symptoms can progress to massively enlarged mediastinal lymph nodes. On chest x-ray, you will see a significantly widened mediastinum, which is well illustrated by the arrows here. Patients can develop pulmonary hemorrhage, meningeal symptoms, and death. So, if you see a board question that says your patient has flu-like symptoms like fever and cough, and also has a chest x-ray demonstrating mediastinal widening, you should steer towards anthrax, as very few other infectious processes would have this image finding. Wool-sorter's disease is also pulmonary anthrax, just the term used for those patients who inhaled spores specifically from contaminated wool products. Bacillus cereus, a related bacteria, can cause either vomiting or diarrhea, usually within several hours. The emetic form is associated with a preformed toxin known as cereulide, which is a peptide encoded by plasmid DNA. The diarrheal form can be associated with different cytotoxins or enterotoxins. The pattern of diarrhea is similar to that of Staph aureus, but the foods associated with B. cereus are reheated rice and pastas. The diarrhea occurs within several hours of ingestion, and symptoms resolve by themselves within several hours. Like Bacillus anthracis, Bacillus cereus forms spores, which may survive boiling and germinate to form toxin during reheating. You might see this on your board exam, so listen up. Your patient comes in with nausea, vomiting, and watery diarrhea. If he says his last meal was 6 hours ago and it was at a picnic where he had potato salad and hamburgers, what is your most likely diagnosis? Staph aureus is correct. But what if he says he ate at a local takeout Chinese restaurant and had a stir-fry dish with steamed rice? Now the most likely diagnosis is Bacillus cereus. Important distinction there, getting you points on the boards. Flash quiz. A 63-year-old diabetic woman develops fever, chills, and cough productive of blood-streaked sputum. Gram stain of a bronchoalveolar lavage shows gram-positive diplococci. What is the most common pathogen? The answer is strep pneumo, which is the most common cause of bacterial pneumonia. Remember the description. Gram-positive diplococci will help you make this diagnosis. On chest x-ray, you would see a big lobar consolidation. Listeria monocytogenes is a catalase-positive, facultative, intracellular gram-positive rod. It is an uncommon human pathogen, primarily affecting neonates or the elderly and immunocompromised. It can produce flagella at room temperature, which is responsible for its characteristic tumbling motility. At 37 degrees, however, the flagella no longer develop, and the listeria then relies on the host's cytoskeleton structure to create an actin tail for itself. These actin rockets allow the bacterium to move from cell to cell. Actin rockets. Some pretty cool buzzwords here. Listeria is commonly found in contaminated refrigerated products such as milk, cheese, and deli meats. As a result, it can cause outbreaks of gastroenteritis. This can cause serious infections in neonates, which take on two forms. Granulomatosis infantiseptica is an early onset form of neonatal listeriosis due to transplacental transmission of listeria. It results in miscarriages or births complicated by sepsis, disseminated granulomas, thus the name, or multi-organ failure. Late-onset neonatal listeria is caused by transmission of listeria during the birthing process and usually presents as meningitis or meningoencephalitis a few weeks later. Listeria affecting the elderly or immunocompromised typically presents as meningitis, bacteremia, or sepsis, and this is usually due to an impairment in cell-mediated immunity. Both of these gram-positive organisms, actinomyces and nocardia, are unique in that they have a branching filamentous structure which can be seen in this picture of a patient who was found to actually have nocardia on biopsy. There are some important differences between nocardia and actinomyces which are summarized in this table. Nocardia is acid-fast, while actinomyces is not. Actinomyces is normal oral flora and can consequently cause facial abscesses, which we'll talk about in a second. Nocardia is found in the soil, and when inhaled can cause pulmonary infections. Finally, the treatments are different. Treat actinomyces with penicillin and nocardia with sulfonamides. I like to remember this with the little mnemonic, oh snap. Remember, sulfa, nocardia, actinomyces, penicillin. Facial abscesses caused by actinomyces can be confused with neoplasms. This patient below presents with what appears to be swelling along his jaw. When you look a little closer, you note there is some yellow pus draining from the edematous area. What is that? This is lumpy jaw, which is associated with actinomyces. The yellow pus, called sulfur granules, drain out through the sinus tracts in the skin, and this is a key sign differentiating actinomyces infection from neoplasm. Flash quiz time. A 47-year-old mail carrier presents to urgent care complaining of fever, headache, cough, and generalized malaise. Chest x-ray shows mediastinal widening and no focal areas of consolidation. What do you expect to see on gram stain? The answer is Bacillus anthracis, which in this case has caused pulmonary anthrax. On gram stain, it appears as gram-positive rods.